People are surprised when they learn that I donated a kidney. Getting ready for this talk gave me the opportunity to think about how I made my decision. It was an opportunity for self-discovery. The first thing that I realized was that making this kind of a decision isn't as simple as weighing the pros and cons. For me, the decision was affected. Sorry, there's a slide. I think. Okay. For me, the decision wasn't just weighing the pros and cons. It was affected by the fact that I really wanted to donate a kidney. Instead of looking for reasons not to donate, I searched for reasons to support my decision, and I trusted that a great deal of care would be taken to make sure that I was taking the least risk possible. This is my story. It's a personal journey, and I know it's only true for me. That said, it's not just my story, so I think I should introduce my family. My husband of 33 years is Chris, our son Mark, and our daughter Haley, in this picture taken at my son's convocation in June. My family didn't share my determination to move forward with donation, but they did support me and my decision. The decision to donate had to be mine. No one in my family really wanted me to go ahead, but they understood why donating mattered to me. If I'd left it up to them, I would not have been given a green light. I think I should warn you, though, that my interest in being a donor started when I attended a talk at BCKD Days a few years ago. A man and his wife told their story. He'd given a kidney to his wife, or the other way around. It doesn't really matter. What matters is that what I went away with was that the donor and the recipient were both well, and the gift of the kidney had been life-altering. When I got home, I told my husband about the presentation. And while he wasn't overjoyed with what I was considering, he trusted that I wouldn't take unreasonable risks. Assessment of risk is a personal matter that's colored by life experiences, and my understanding of medical risk stems in part from something that happened 20 years ago. We were planning to have our second child, and my doctor explained to me that my risk of having a baby with a genetic abnormality had doubled because of my advanced age. When I saw the obstetrician, however, he framed it quite differently. He said, yes, you have a 5% chance of having a child with a genetic birth defect, but you also have a 95% chance of having a perfectly normal baby. And he went on to ask me, if someone told you that you had a 95% chance of winning the lottery, would you buy a ticket? During the same period of time, I used medication to enhance fertility. This came with the risk of increased ovarian cancer, or the increased risk of ovarian cancer. But since I really wanted to have this baby, the risk didn't stop me. Wanting something made me look at the associated risk in a different way. There are lots of things I consider way too risky. I'm not going to be going skydiving or bungee jumping or scuba diving. But the truth is, I don't really want to do those things. My husband and I talked about the practical risks of donation, things like loss of income, use of my sick leave, impact on vacation plans, and out-of-pocket expenses. At the time, we gave these things more consideration than what I considered the minimal risk of loss of life or a future with kidney disease. And to be honest, I don't think we really talked about those. I decided, and my husband accepted, that I was going to move forward. This decision was definitely mine. I didn't talk about donation with my children or my sisters or my friends until many of the barriers had been removed. Once I had made the decision, I proceeded cautiously. I have a lot of respect for the physicians in our renal program, so it was reassuring when very early on I spoke to one of our nephrologists, and she told me that barring any problems during the actual surgery, studies suggest that the long-term health of donors is as good as or better than the general population. My next step was to talk to the director of our renal program. This was the first time he'd been approached by a staff member who had decided to be a donor. When I was given a surgery date, we talked again. And at that time, he said he had no idea how he was going to do it, but he pledged to cover my wages while I was off work. In the end, I learned that Island Health has a policy to make organ donors whole. It was, however, a very well-kept secret. When I talked to my kids and my sisters, their reactions were mixed. My son offered me one of his kidneys if I need it in the future. My daughter was frightened and a little angry. My oldest sister thought I was misguided. Her words were, "What next? If someone needs a hand, will you chop yours off and give it to them?" My other sister said I was her hero. Most of my friends just worried and prayed that I would be okay. One of the biggest risks for me was that people I cared about might believe that I didn't really care about them. I imagine we all know someone whose life would be transformed by a transplant. I've had lots of patients ask me to donate a kidney to them, and I never know how to respond, and I tend to change the subject. Even so, with those uncomfortable conversations, it gave me a chance to start thinking about the possibility of donation. And I've learned a lot from people who are on dialysis. They don't give up, they don't take life for granted, and for the most part, they live each day to the fullest. And I'm constantly amazed by their resilient spirits. I have a sister who volunteers with orphans living in a garbage dump in Guatemala, and a friend who's working with the United Nations in Ethiopia, registering refugees from South Sudan. I'm the first to say that I'm not a saint. I can't see myself doing any of those things because I'm not prepared to take those risks or make those kinds of sacrifices. But I've always really wanted to make a difference. I know over 150 people on dialysis for whom a kidney would mean new life, and I saw donation as my chance. I'm not a risk taker. Many people who know me would describe me as conservative. I take safety pretty seriously. I use seat belts, I wear helmets, I have vaccines, I have mammograms, you name it, I do it. That said, I couldn't think of a good reason not to move forward. I'm blessed with good health. I'm not smug about that. I do what I can to stay healthy, but I can't take any more credit than that. I have friends who have Crohn's disease, type 1 diabetes, chronic pancreatitis, migraines. They just aren't as lucky as me. I was healthy enough to be a donor. For once, my age was on my side. The fact that I've lived this long without developing a chronic disease made it easier for the transplant team to assess my suitability as a donor. I counted on them and trusted that they would get it right. My family is pretty healthy. There is a chance that someone in my family might need a kidney, and now I can't be their donor. But there's no kidney disease in my family. Our son was in his late 20s and our daughter in her early teens, and both were healthy, so I didn't expect them to need a kidney. I'm not getting any younger, and the older I get, the more likely it is that my health could change and then I wouldn't be able to be a donor. And I've developed this fairy tale in my mind, maybe because I'm a fundamentally unrealistic person and I tend to wear rose-colored glasses. I convinced myself that the process was going to be easy. I believed that the 2 months after surgery was going to be 2 months of vacation, and I like vacation. As it turns out, donating a kidney was a lot harder than I expected it would be. Our family lifestyle depends on both my husband's and my income. If I lost wages or had to pay my own expenses, I would not have been a donor. My donating depended on it not costing me a lot of money. Being healthy means that my sick leave bank is healthy too. If I had needed to use sick time, I would have. I had plenty of sick time, but it occurred to me that if I used it all up in the donation process and then got sick later, I might not have enough sick time to cover that. Being told that my wages would be covered made my decision easier. The Kidney Foundation reimbursed me for transportation and accommodation costs during the evaluation and donation process. I did use a little bit of sick time early in the evaluation, but the pre-transplant team arranged the appointments to minimize travel and accommodate my work schedule. As a non-directed donor who was starting a chain of transplant events, I was allowed to veto proposed surgery dates that conflicted with our travel plans. We enjoyed our family vacation, and while I felt a little guilty about putting off the donation, it was really important for me to spend that time with my family. As a non-directed donor, I was also allowed to limit the transplant centers that I would travel to. At first, I thought it would be really fun to be able to travel somewhere else in Canada, but in the end, that would have made the process much more difficult for me. I believe extensive donor evaluation is done to protect the donor as much as the recipient. I felt the process was set up to rule me out. I had many blood tests, blood pressure readings, x-rays, ultrasounds, and even a psychiatric evaluation. One of the tests I had involved having dye injected before a scan was done. My whole body flushed when the dye went in, and for a few moments, alone in the examination room, I quite honestly thought I was going to die. I wish I had been better prepared so that I'd known what to expect. But even so, passing all the screening tests made me feel more at ease with the risk that I was taking. There is another risk when you have so many tests done. By way of explanation, I have a friend who went to a private clinic and had all kinds of tests done. There wasn't any indication for any of these tests, but in the process, there was a lump found on her thyroid. Knowing that that lump was there caused her a lot of anxiety, and so she had surgery, and now she's on medication for the rest of her life. Who knows if the lump would ever have caused her any problems if she hadn't known it was there. On the other hand, maybe knowing saved her life. So I wondered if the transplant assessment would uncover a previously undiagnosed medical condition. Happily, nothing showed up. Even so, there is now a good chance that with just one kidney, if I need to get life insurance, it will be much harder to get. The life insurance I already had, though, wasn't affected. I knew there were risks, but we face risks every day. I jog alongside traffic, I go for walks in the evening after dark, I drive my car to and from work, and I don't even think about the risks that are involved. I think I may have been an ostrich in a former life because I do tend to bury my head in the sand. I know that things can just happen and that bad things happen sometimes, but I try not to dwell on that and I live my life. There are known risks when you have surgery. The pre-transplant team provided me with some statistics. During donation surgery, the risk of dying, having a heart attack or a stroke is 3 in 10,000, or 0.03%. I added this to the other nasty complications like embolism or deep vein thrombosis, and got a total risk of 3.63%. I don't even know if you can add up percentage risks that way, but that's what I did, and 3.63 didn't seem like that much. To me, it meant that I had a 96% chance of these things not happening, and that was a pretty safe bet. It was hard to give over the control to the surgical team. I met the surgeon during the screening process and then again in the hospital on the evening before surgery, and that did help to lower my anxiety. Now, I've worked in the hospital systems for over 30 years, but probably unlike many of you, I'd never been in an operating room, at least when I was awake. For the other operating room virgins, it would be really helpful to know what to expect. I have vivid memories of equipment and people rushing about and bright lights and everything moving very quickly and feeling really anxious. And then happily, I don't remember a thing. I have always felt that it's easier to be the one who is sick than it is to be the family and friends who have to deal with the worry and the anxiety. My husband was very worried. He stayed home to be with our daughter, and I really don't know if it would have been easier for him if he had been with me. I know he would have worried anyway. The surgeon phoned him to let him know that the surgery had gone well, but the surgery took longer than Chris had anticipated, so he worried. Not being with me was really hard for him. It is hard for others to watch and wait, but I think you need someone with you. I had a friend who visited me twice a day, and it would have been really, really lonely without her. My daughter was frightened and upset around the time of surgery, and nothing I said or did would change that. I'm not sure that she really understands why I donated, but I think she's forgiven me. One aspect of being a non-directed donor is secrecy. The program asks you not to reveal when or where you're donating so that no one can connect the dots and figure out who has your kidney. I didn't want my friends and colleagues to worry about me. Having 2 months off work with no way to explain it is a little tricky. I did tell a few people at work just so that they could reassure others, because I didn't want them thinking I was really sick. One risk that the transplant team and the psychiatrist pointed out to me was that other people might feel pressured by my actions and might resent me for what I'd done. And I'm happy to say that that hasn't happened yet. I stayed in hospital for 5 days, and most of that time was pretty blurry. I took lots of medication to manage pain and nausea. The incisions were tender, but it was my back that was really sore. I was one of the unlucky 25 to 30% who have back pain after laparoscopic kidney donation. I had other concerns while I was in the hospital. I'd been warned that my personal belongings might not be safe, so I had my phone hidden under my pillow. I hadn't anticipated how much energy it would take to walk around the nursing station. It was exhausting. My friend had to put lotion on my feet because I couldn't reach them. And I really didn't want to be a burden. I may have heard what I wanted to hear, and because of that, my family and I were not really prepared for the first couple of weeks of recovery. In my fairy tale, I felt fantastic by the time I left the hospital. In reality, when Chris and Haley picked me up, I wasn't moving too well. They loaded me into the back of our car without a seatbelt, and I slept most of the way home. For days, I slept in our recliner with pillows under my legs and heating pads on my back, and the intense back pain went on for a few weeks. And then there was the constipation. But I guess you can learn from every situation. I learned empathy for my patients, and more importantly, I learned that if you mix lactulose with a little bit of juice, it doesn't make you throw up. I don't know how many times I've glibly told patients to take lactulose without knowing how really horrible it is. But now I'm able to provide this new knowledge to my patients. This is a picture of me sitting on the far, whatever this is, right. 12 days after surgery, I made it to watch my daughter play volleyball and to the campfire after the games. I felt like a little old lady getting down to the beach, and I wore the only pants that fit me for the entire weekend, and I couldn't be far from a heating pad, but I made it. The transplant team had wanted me to stay near the hospital after discharge. They suggested that I move into a hotel for a few days so that I could see the surgeon before going home. I took the risk and I went home because I needed to be looked after by my family, and I think my family needed to look after me. I did receive follow-up care from my family doctor, and the transplant team got a few phone calls. I like to run, and it worried me that it would take a long time to get back into my exercise routines. The first walks I took were less than a block, but after a week of being home, my husband and I had progressed to walking for 15 minutes all at one time. My first solo walk was an adventure. It took half an hour, including stopping to rest 3 times, to walk 5 blocks to visit my mother-in-law. I was astounded how little stamina I had. I rested for about an hour before attempting the return trip, but I was back to jogging ever so slowly 6 weeks after the surgery. I don't mind having little scars, but I didn't want big, ugly ones. And I do have a few small scars, but they're fading, and it's not like I'm going to wear a bikini anytime soon anyway. I often wish that I had a magic wand to wave and make my patients' kidneys work. It was really hard to decide to be a non-directed donor when so many of my patients desperately needed a kidney. These are people I really care about, but ethically, I could not select one of my patients over another. I had to be satisfied that the last kidney in the donation chain was going to someone on the deceased donor list. Being a non-directed donor means that I don't know who has my kidney. My loss is that I wasn't able to watch the recipient recover and gain any satisfaction from that. On the other hand, I don't feel any responsibility to look after the recipient. My responsibility ended when my kidney moved on. My GFR, right after surgery, was 45. A year later, my GFR was 54, and the last time it was checked, it was 58. It's not necessarily what I had hoped for, but it is what it is, and I'm thrilled that it's going up. Since surgery, my blood pressure has on occasion been as high as 127/70, but it's usually closer to 110/60. I believed going in that my long-term risks were pretty low. It turns out that the research is still going on. So I decided that I would join the study, both so that the risk would be better quantified for others, but also selfishly because I figured that I'd get closer monitoring and that would be a good thing for my health. I continue to believe that the more you know about your health, the better armed you are to keep yourself healthy. When people ask me why I donated a kidney, the answer is simple. I became a kidney donor because I could. Had I known then what I know now, would I still have donated? Absolutely. Thank you.
It's a big deal to be a kidney donor. It's a really big deal, and kidney donors really are heroes. I have the privilege of meeting people every week who want to donate. I would say that it's 30-to-1 of people who are worried that I'm going to tell them something that I'm going to find something, I'm going to tell them something that is going to mean maybe they can't donate when they've already made up their minds they want to donate. There are very few people who come even with the slightest bit of concern or worry about it. They're committed, and talk about walking the talk. They really do. So I do want to talk about risk, and I was very interested to see what Eileen would say about risk, because what the medical team, I think, perceives as risk and what potential donors perceive as risk may be quite different. And I think that it's very important that we both donors look at, understand a little bit what the physicians are worried about, but physicians also understand a little bit about what donors are really thinking. So I wanted to talk about our thought process in terms of understanding risk and some of the ways of transmitting our thoughts on risk to donors and the way that donors understand risks. So I do have some disclosures. Apropos of what we were talking about this morning, I want you to trust me. And I said that facetiously, but it's critical to me that when I have a relationship with the donor, that the donor does trust that I'm there for them, that I'm doing my best to serve their best interests, and that my only interest is helping them do what's best for them, but sometimes be in the position where I have to tell them what's best for them rather than what they perceive as what's best for them. But I do derive my money from my living from looking after transplant patients. So if we do a lot of living donor transplants, I'm going to get paid more, and I guess that's going to contribute to my quality of life. And so I want people to know that I do walk with, I do carry that, and I take that responsibility, and I'm willing to address that with people. I'm also passionate about living donation, and I'm maybe you'll trust me more when you know that I'm the national chair for the Canadian Blood Services Advisory Committee on Living Donation. But I really have a lot of enthusiasm and energy and really drive to promote living donation. So that's a bit of a disclosure. I have some objectives. I want to give you a framework to talk to donors about risk, but I also want to point out where we're at today with risks. And I'm going to come to two publications which have appeared in the medical literature in this past year, which have, I think, given everybody a little bit of pause and say, well, we better think about that a little bit more and find out a way to contextualize that for our patients. So it's a little bit of philosophy, a little bit of ethics, and a little bit of science, but how do people make decisions around risk? And so I think it's important to think, I believe that everybody sort of looks on the one hand, what's the risk, and on the one hand, what's the benefit, and believe that for a living donation, that the benefit way outweighs the risk. The benefit goes all the way down here. That's really heavy. The risk is pretty light. But we explain the risks to everybody. The risks are clear, but for some people, that description of risk, I tell them what the risk is, and they say, oh, well, that's really not very high risk at all. And actually, from their point of view, the scale moves up. But then there's somebody else who hears the same risk, and the way they view that risk, well, that's a really big deal. And so just telling people the risks may not be enough to really understand where they're coming from. So even the decision makers have a little trouble with this. So this is a chart where we're looking at various scenarios, and going across the top, it's how likely something is to happen, and going down the bottom, it is how bad it is. Going from bottom to top, the worst then is something that's catastrophic, but luckily, so the risk of dying, which would be a catastrophe, is very unlikely. So in this schema, the risk is felt to be medium. Well, but a similar chart produced by a different organization, looking at the same degree of risk, the catastrophe and the unlikely, came up with it as green. So I think risk is in the eye of the assessor, and so some people will look at that risk and say, hey, I looked at that and, I'm willing to take that risk, but wrestling with sharks probably wouldn't be a risk that most of us would take. But on the other hand, I think, most of us realize that if you are not willing to take any risks at all, then what is your life really worth living? So I said a little bit of philosophy. So we spend a lot of time presenting risks to our patients, and I think I've learned that all of these things which we say, they roll off our tongues. These are just part of our vocabulary. Oh, it's safe. That's a low-risk procedure. Actually, you have a bit of an increased risk. You have a 3 times increased risk. You have a 10 times increased risk. What does that really mean? And I think, people will choose to hear from the point of view of where they're looking at, where they're coming to from that. And so if you hear it's low risk and you want to be a kidney donor, low risk sounds great. Another person will say, low risk, well, is there any increased risk? Yeah, they say, well, that's twice the risk if you didn't do it. Oh my God, twice the risk, that sounds really bad. So what I've discovered is that the only way that I think you can be clear, transparent, and perhaps reproduce for the prospective donors, what the risk really is by presenting to them in a graphic type of form where you're really clear. And so I've taken to you, I don't like the picture so much, but I use this word game. And so let's say I want to get across to them that the risk is 3 in 10,000 or 3 in 1,000. So I say, well, we're going to fill up a jar full of jelly beans, and we're going to put in 1,000 jelly beans. 997 of them will be white, and 3 of them are going to be black. We're going to shake up the jar, and you're going to close your eyes and stick your hand in. So if you get a black jelly bean, you're in trouble. It's not as if if you get a little bit of the black jelly bean mixed with the white jelly bean, so it's all or none. So this is, are you willing to stick your hand in and take that jelly bean? If you say, well, there's only 3 of them in there, sure, I'll do it. I think then you begin to understand what I'm really talking about risk. So I'm not going to talk about risk of surgery. Eileen covered that really well, and so she was drawing into the jar with 100 jelly beans, and she was going to pull out potentially pull out 1 of 3 black ones, but those wouldn't be fatal jelly beans. Luckily, there would be the 3 in 10,000 ones to be the fatal jelly beans, but the complications. So I'm not talking about surgical complications now. I'm not talking about the risks of surgery, but I'm talking about in the long term. So when I say to donors, my job is to look at you and your overall health and saying, can I foresee a situation 10, 20, 30 years from now whereby we would have said, that was not a good idea. You should not have donated that kidney. We really regret that you made that choice. Now, clearly nobody has a crystal ball, so again, I'm only doing my best to project risks, but I need to understand what those risks are. So is there a risk of dying prematurely because you're a kidney donor? And is there a risk of going on and developing kidney failure? Those are the 2 biggies, and those are the things I want to focus on. So why is mortality an issue? As Eileen said, there is a lot of medical literature going back a long time suggesting that in terms of life expectancy, living kidney donation is very safe. And the first study, the one that I think is the most widely quoted, comes from Sweden, and the first author is a nephrologist who actually herself was a kidney donor. And so she, came from a certain mindset about it being safe. But they then compared kidney donation to the normal population, and in all of these studies, you can see on the top part of the curves are the donors. On the bottom part of the curves, the second curves, the ones below the top ones, are the general population. And in all situations, the living donors live longer than the general population. And so that's really great. But the point is, well, of course they should live longer because they're healthy. They don't get to be a kidney donor unless they pass all your testing, and therefore these are people who are destined to live a long time. So you're really not comparing, it's not really fair to compare a living donor to the general population. You should compare them to themselves. And so everything I'm going to say from here on in is the problem is that we're not able to compare them to themselves. And so we do our best to come up with a controlled population, to come up with a group of people that are fair comparators for the donors, but we don't have that. Eileen has talked about going into a study, which is a long-term study, which is initiated, which is a Canadian-wide study, which we're now a number of years into. But in order to really see the results of true comparators, so a perfectly healthy donor versus a perfectly healthy person just like them who didn't donate, to get the real results, you got to follow those people for 25 or 30 years. So we don't have that. So we make up control groups. So this is from Amit Garg, who's our colleague in London, Ontario, and from Dori Segev, who's a transplant surgeon in Baltimore. And they both tried to come up with a healthy comparator group, one in the OHIP database and one in a study. And basically, in Ontario and in the US, when compared to healthy controls who they felt matched with their recipients, there was no difference or there was still a better outcome. So we're feeling pretty good about not causing any premature death in donors until this paper came out. And this was published in Kidney International, and it comes from Norway. And this was the first, I think, really red flag that the enthusiasm, the people who were very enthusiastic about donation, had to stop and say, well, we better take a closer look at that. And so this looked at all kidney donors in Norway from 1963 to 2007, 2,200 or more, and they compared them to a general population who they thought were pretty healthy because they had enrolled in a study, a long-term study called the Hunt study, which was looking at cardiovascular health. It doesn't really matter why. And they selected out of that population people they thought were healthy. And they used that group because they thought it was a healthy group and they had good follow-up on those people, so it was convenient to then compare them to the donors. And so they compared 1,900 donors to 32,000 controls. And the drama here is that there's a separation. And this time the curve for the separation is that the donors are actually doing worse than the general population. And so there was an increased risk of death in donors as you went further and further out. As you went to 25 years, that was a 30% greater risk of death. So the question is this real? I mean, is this a valid comparison? And so the first thing you need to make sure is this a true control group? Are we really comparing apples to apples? And so you can see that the controls were younger. You can see that there were more smokers in the donors, surprising, but that was those were going back a long time. And even blood pressure was a little bit higher. And so when you really look at it, my conclusion is, and I think the conclusion of, not just transplant people, but impartial people, is that they were not comparing apples to apples. They were comparing apples and oranges. And in their control group, first of all, they were a very small segment of the population of Norway. It came from one community only. And the donors came from a different era than the controls. The donors came from an era much before that. They were older. They were older when they started to donate, and they were older at follow-up. And then, therefore, there was some lead time bias in terms of when you would discover things like death. And I think I think anybody who's following the literature people might say to you, what about this paper? And I think it's reasonable to say, well, there was too many methodological flaws, and I really just don't buy it because I don't think they had an accurate control group. And then we're somewhat reassured by a paper which came out right after that in the American Journal of Transplantation, where I guess I would argue that they had a better control group. They had contemporaneous controls, and they were capturing data in the same way. And in this group, I'll just slip over, is that the donors they're in red, and their healthy controls were in the darker color. And in this situation, in donors over the age of 60, which is where you're going to see the most early, they're going to get older more quickly, and therefore they're more likely to die. You can see a separation where the donors are doing better. So I think I'm comfortable when talking about risks to say to donors that in terms of your life expectancy, yes, there's a risk of the surgery itself, but in the long term, the very important question of, is this going to take years off my life? I think I'm pretty comfortable saying, no, I don't think so. I don't think that this is going to take years off your life. Then the other question is, what about kidney disease? So am I going to regret 20 years from now that I only have one kidney, and now I got kidney disease in that kidney myself, and I just don't have the reserve that I had when I'm 2, and is there a risk that I'm going to end up on dialysis? So again, historically, a number of studies looking at longer-term follow-up in donors, looking at the risk and the rate of end-stage kidney disease, yielding very small numbers. And again, reassuring to say to people, no, the data shows that your risk of getting kidney disease is no worse than the general population. In fact, it's actually lower than the general population. Then this article came out. You know, and this was from the Johns Hopkins group, and the senior author was Dori Segev, and Dori's a transplant surgeon who's actually been here to speak to us, I think, maybe even on BC Kidney Days, and Dori's a great guy. And Dori's passionate about living donation, so he was not somebody who's looking for evidence that living donation isn't safe, but he's a very credible researcher, and I would give them credit that they did their best to present a story which they felt was accurate. And so their study looked at all donors in the U.S. from over a reasonable time span, and they tried to determine for all these donors how many of them actually ended up on dialysis. And so they had almost 100,000 donors. And at the end of their study, 99 of those almost 100,000 donors ended up on dialysis. And so if you do incidence, and there's a lot of mathematics, and there's an awful lot of mathematics. And so I will bore you with some of the mathematics, but I'll try to simplify it. There's all sorts of numbers, and a lot of this is manipulation with numbers. But just remember the number 30. So 30 in 10,000. At 15 years, or 3 in 1,000. And that's the number of 99 cases of chronic kidney disease, so an incidence of 3 in 1,000 at 15 years. And then what they tried to do is find the right control group. And so they knew that there was this a totally different study, but a control group who they had access to the database called the NHANES 3 study. And from that database, they extracted about 10,000 controls. So they had 10,000 controls and 100,000 kidney donors. And then they tried to compare the risks of chronic kidney disease in these two groups. And this is the slide, is that in this group, they found a very, very low rate of chronic kidney disease beyond dialysis in the control group, and the rate that I was telling you, the 3 in 1,000 or 30 in 10,000, in their living donors at 15 years. And so that, one way of looking at it is, oh my God, it's 10 times the risk. Another way of looking at it is it's 10 times a very, very small number. So 3 in 1,000 still is a pretty low risk, but the more press likes creating excitement, and it's more exciting to say it's 10 times the risk. But I'm going to show you a few slides for me to argue that I really don't believe that risk is that low in their control population. And I don't want to bore you with the slides, so I'll gloss over them, but maybe you trust me by now. So if you trust me, you can say, well, it's just that they didn't do it right. Maybe that control group's okay, but it's all statistics, and they didn't do their statistics very well. Or I'm going to show you a few reasons for you yourselves to be able to rebut people who say, well, what about that paper? So first of all, they assessed end-stage renal disease in different ways, because the NHANES cohort, they didn't have access to the activation of the transplant waiting list. And here, you can see that the NHANES cohort was 88 to 94, and the donors were 94 to 2011. And the form that you used to identify chronic kidney disease didn't even come out till 1995. And so a number of donors who had chronic kidney disease would have been missed because they didn't have access to the deceased donor waiting list, to the waiting list information, and it wasn't being collected on the forms. And I think I had another thing there, but it was clear then that the event rate in the control group could have been too low. But the big deal is that they had 10 times less control patients than they had true donors, and so they had to do some matching so that they could use one control patient would then match to a whole bunch of different patients. But it wasn't matched 1 to 10. Like, okay, you go for these 10 guys, you go for these 10 guys. They did a whole bunch of manipulations to try and come up with who they were going to match to whom. And so in the overall amount, they had 17 end-stage renal diseases in their healthy controls. Those 17, they then translated into that very low risk. Whereas there were 36 so that 17 only came out to 36 in their simulated group. A bunch of balls. You can see that if they then, if somebody with chronic who developed chronic kidney disease was only used 1 time or 3 times matching the controls, that would give it a very low number. But let's say they had matched that, they'd used that donor 20 or 30 times, then that rate would have come up way higher. So they never told us how they did that, and they never said how, what the mix was for their so-called match. And I think that's a big flaw. And so I think, so this this event was rare, and then they say was, when they then extrapolated from the 10,000 patients to the 100,000 patients, it was still incredibly rare. And so I think without knowing the frequency that they were included in the simulated cohort and how they actually matched, I think it leaves us to say, well, what if it was just one, if that one donor, that one control who got chronic kidney disease was used 10 more times, then that rate would have been much different. And so what I can conclude from the study, and what it's really good for, is that actually, so the risk of chronic kidney disease ending up on dialysis for Americans over that period of time is 3 in 10,000 at 15 years. But I think it's fair to say that all of us now believe that if you are a kidney donor, I think we've always believed this, but we didn't maybe say it as clearly as I'm saying now. If you're a kidney donor and you only have 1 kidney, and then another problem happens to you whereby you're going to lose kidney function, that will result in you losing kidney function more quickly with 1 than 2, and could make the difference of you ending up on dialysis or dying from old age with maybe some declining kidney function, but still enough kidney function to keep you healthy. And so this is a slide which looks at sort of the trajectory of chronic kidney disease in people who were donors who ended up on dialysis. And you can see that there's always a second hit. There's something else that happens later in life which then causes them to lose kidney function. And I think it's fair to argue that that would happen more quickly with 1 kidney than with 2. And so I think I went the wrong way again. So just to contextualize it in a Canadian context, this is from our colleagues in Alberta, both Calgary and Edmonton, and basically they're looking at the Alberta population, and if you live long enough, it's not horribly unlikely that you could end up on dialysis. So approximately 1 in 40 men and 1 in 60 women, if they live into their 90s, are going to end up with chronic kidney disease. So there's a 2.66% risk of kidney failure for men and 1.76% for women if you live into your 90s. Now, if you're a kidney donor, if that would have happened in your 90s, maybe it's going to happen to you in your 80s. Okay, so now you only have 1 kidney, and things are going to shift a little bit earlier. And so I think that it is reasonable to say that there is some concern, and so it's our job then to do our best in identifying these people. So I'm going to tell you now what I believe, is that I believe that our donor workup, which is extensive and very thorough, will be able to identify, especially in older people who have risk factors where it would make us say, well, when you're in 20 years from now, maybe that's not going to be a good idea. We're not as able to do that for somebody who's 20 or 30. The only reason being that when you're 20 or 30, you're very likely to be healthy, but you got a lot of time. A lot of stuff can happen over those 30 years, and some of those are things that we can't predict. And so today, I love older donors. I feel very confident with older donors to look at them and say, you're already 55 years of age, you don't have high blood pressure, you don't have diabetes. Those are by far the biggest drivers of chronic kidney disease as people get older. Even if you do, you won't get diabetes for 20 years from now, and if you get diabetes and you get kidney disease, well, if you're going to lose kidney function, which you probably won't, but if you're going to lose kidney function, that's going to happen over the next 10 years. So maybe we're worrying about when you're 95. That's okay. So people will say, yeah, great, sign me up. But when you're 20, you think everything's fine because you're totally healthy, but there's just a lot of years. And so I think all of us, in terms of living donation, have reevaluated, where we stand with younger donors. And another point is that, kidney function matters. That should be obvious. So as part of our desire to standardize across the country, the Living Donor Advisory Committee has now developed consensus guidelines for the acceptance of kidney donors. And so we look at things like kidney function, risk of diabetes, blood pressure, and other things. And so the younger you are, the more stringent we are with GFR. And so these are the national consensus guidelines for your kidney function has to be this good if you're under 30, but as you get older, you don't have as many years that you need that remaining kidney to last. Therefore, we're going to accept lower and lower GFRs. Similarly, we're worried about the development of diabetes, but maybe we're being too strict. And so if somebody's 50 and maybe has, in the second example, you are pre-diabetic. You got impaired fasting glucose, but are not overtly diabetic, but you're already 60 years old. What are the chances then that you're going to develop diabetes and kidney failure from diabetes in your lifetime, so it's going to affect your kidneys? We think it's reasonable to take some risk with older donors, but we're certainly not willing to take that risk with younger donors. So age really matters. Similarly with blood pressure. If you turn down high blood pressure, maybe is in 25% of the population, 30% of the population if you look for it carefully, and you'll rule out an awful lot of donors who maybe would be fine if you were too stringent. So our guidelines now is we're going to accept hypertensive donors who are well treated on a single medication if they're over the age of 50. And microscopic hematuria you don't really need to hear about. So I'm going to end with a little bit of philosophy again. There are going to be some gray areas. And usually it's actually the transplant team which is saying, hold on, I'm worried. And it's the donor that's saying, no, I hear you, but I really want to do this. And so, who's driving the bus? So I really believe that having a patient who's well informed, a patient who actually understands risks, a patient who can convey to you about pulling the jelly beans out of the jar, and can make that, is able to make a decision for themselves that they're willing to take that risk, because on the other side of that, there's a benefit. Eileen it would be on the extreme of not being able to actually see that benefit, would know about that benefit, but hasn't even seen that benefit because she was an anonymous donor. But for most donors, they see their loved one. They see the benefit of the living donor transplant, and they feel that for me to help that individual, it's worth it for me to take that risk. At what point then do I say, well, I don't care, you're not going to do it? And so again, that's a moving target, and some programs are extraordinarily stringent. Other programs are a little bit more liberal. At some point, everybody has a fine line, has a hard line, and says, I don't care what you say, that's just too risky. I think living donation has moved. I think that line has moved. My goal is for the potential donors to be able to clearly define what it is that they're getting themselves into, and then to come to me and say, yeah, I'm good with that. I'm at peace with that. And if they're at peace with that and it's not pushing my line and it's not pushing our surgeon's line, because let's face it, the surgeon's the person who's taking the most responsibility here, because they're doing the operation, they're actually taking out the organ. If we feel they know what they're doing, they're going to help somebody, we're going to help them help somebody, for me, then that's what it's all about. So in the end, I think informed donors being able to make important decisions to help people really live a better, longer, more rich life is what living donation is all about. So I think Eileen and I would both be happy to, I think Eileen will come up, and both of us would be really happy to take your questions. Just while Eileen's coming up, I want to thank John Gill is aided by JAG, but I think John's was obsessed with finding ways of putting those two papers into a context which would make us feel that we were really looking at apples and apples, and John did an amazing job of breaking down especially that second paper, and he lent me a slide, so I have to thank him.
So thanks very much for two fantastic talks. We do have some time for questions. Just before we get to that, just everyone can stay seated, because the food will be coming in the next little while to your table, so we don't have to go out and get food, so that leaves us some time for questions.
Do you think we should be taking more responsibility as a community for the donors and actually doing annual follow-up with them every year, even though, their GFRs wouldn't make us have them as patients chronically usually?
So we do collect follow-up data on all our donors. We send them. We ask them to do a GFR at early after the surgery at 3 months, and then annually we ask them to get their blood pressure tested, their urine dipped to make sure their urine tested to make sure they don't have proteinuria, have their blood sugar tested, and if they're good for a year. We actually collect that. It does come in. Nurses review it. If there's if there's a value out of line, we then go to the GP, through the GP, and usually say, hey, did you know about this? Could you please have a look at it? I think I'd like to spend 2 minutes commenting about GFR. So the way we measure GFR is, in healthy people, is not very accurate. The eGFR by the MDRD in healthy donors underestimates GFR by quite a bit. A nuclear GFR does a measured GFR does a much better job of making the GFR accurate. So a lot of family doctors and a lot of patients, or a lot of donors now, will freak when they see that first eGFR as being 47. However, when they did their initial workup, their eGFR was 80. Okay, but their nuclear GFR was 105. So if the eGFR started off at 80, then it's going to go down to half of that right after donation. The nuclear GFR, which is a more true GFR, is the number is going to go down, but the actual true GFR is actually higher. And so now I write a letter to every family doctor and say, prior to donation, this was the eGFR and this was the nuclear GFR. Look, there's a little difference there. This is what I would expect the eGFR to be after donation, and this is a range that I wouldn't worry about. So when Eileen's eGFR was 47, knowing that her eGFR before was 80, but her nuclear was 105, I'm good with the 47. Does that make sense?
The other thing that I wanted to say is that I'm probably off base, but I don't consider myself to have stage 3 kidney disease. It's a number, and I have a healthy kidney. I don't have a kidney that's deteriorating.
Yeah, I think there's a lot of literature on that to say that, you know, there's great things about EGFR, but it doesn't serve donors, or it's not correct to say that they have kidney disease. I think, as I said, there's a lot of trouble with the estimation. We're going to CKD epi next week or tomorrow maybe. Whatever. So it's a bit better. It still underestimates GFR in donors, but yeah, I think that's enough.
Any other comments or questions?
Just curious, can you compare the two kidneys so that as a donor, say, I want to keep the better one?
Yeah, so that's what the nuclear does. So the nuclear, you actually get a split. And so it will say right kidney 52%, left kidney 48%. So we will never leave a donor with the less good kidney. But if there's a big split, then maybe nobody really wants that not so good kidney. So we do insist on knowing the split.
A follow-up question to that, I know it'd have to be anonymous, but is there something that's done to, in the case of Eileen, are we going to track her GFR with her recipient's GFR, even if the two never know who they are? Would the researchers want to keep track of her two kidneys to see how they relatively compare?
Jack?
David wants me to answer that one. I wasn't expecting that. No.
John does the stats, and Jack does it.
So, I mean, I think that there is some value to that. That's something that's been thought of. There's a number of factors that limit that. So if you look at what happens to a recipient's GFR post-transplant, there's a number of additional factors, obviously, that make it a tough comparator. So the immunosuppression in and of itself is going to impact your GFR after transplantation. Obviously, you're someone who actually truly does have chronic kidney disease and comorbidities such as diabetes. So it probably isn't the best comparator to see what's happened. Now, could you look at the trajectory and see if that means something? Potentially, but I think it would ultimately be a problematic comparison.
There's another interesting point, and that is that I've been told that a year post-surgery I could send a letter somewhere saying that I wanted to meet the person who got my kidney, and sort of like an adoption, if they also sent that letter, that we would meet. And at this point I've chosen not to do that, but you know, that certainly would be a person's option.
So just one final comment, I think. I think David did a great job going through and highlighting the complex landscape of the studies. And I think it's overwhelming sometimes when we're talking to patients and trying to contextualize some of this information, because we have to understand it and then process it and then be able to articulate it. And I think that is much trickier than it seems. And one major issue that you have to remember with all these studies these are associations. And so, when a patient comes and asks me, or David, or anyone, and says, will kidney donation cause kidney disease? And I think there's no evidence in my mind that shows that that's the case. As David articulated, you see kidney disease among kidney donors, but that's not the same thing as kidney donation causing kidney disease. So that's just a little kind of footnote that I think is important to remember. So if there's no other, there's another question.
I'm just curious about the number of patients that you would actually see in a year that are volunteering to donate their kidneys.
So right now it looks like for every one living donor transplant which goes ahead, we at least have some contact through various points of workup with at least 5 donors. So if we did 125 living donor transplants, that means we probably assessed about 600 donors in the last year. So, a significant number of people. Some of the fall off through the processes, people, then say, well, maybe that's not the right thing for me. Others are because of the metal. They fall off at various points with the rigorous screening. But there's a lot of people who are willing.